Hello, and thank you all for joining us today. My name is Peggy Clark, and I'm the co-director of Aspen Ideas Health, along with Ruth Katz, and the executive director of Aspen Global Innovators Group at the Aspen Institute. And most of you know that in a normal year, we would be ramping up to host the annual 3-day Aspen Ideas Health event in the mountains of Colorado in June. And while we're disappointed that we won't see you all there to gather in person this summer, we believe that the need for focused, factual conversations in health, medicine, and science has never been greater. So we're hosting this series of virtual conversations with the goal of connecting you to clear information and visionary solutions from leading health experts. So today we're thrilled to host Dr. Patrice Harris, President of the American Medical Association, and Joanne Keenan, Executive Healthcare Editor for Politico. Dr. Harris is a psychiatrist from Atlanta. She is the president of the American Medical Association and the organization's first African-American woman to hold this position. Dr. Harris has experience as a practicing physician, a public health administrator, a patient advocate, and a medical society lobbyist. Dr. Harris continues in private practice and is an adjunct assistant professor at Emory University and an adjunct clinical assistant professor at Morehouse School of Medicine. Welcome, Patrice. Welcome, Dr. Harris.
Thank you very much. It's so good to be here.
Wonderful. And we are also delighted to have Joanne Keenan with us. Joanne is a regular moderator for us out at Aspen Ideas Health, and she is the executive editor of healthcare at Politico, where she's led an expansion of its health coverage while also contributing to the Politico Agenda Policy magazine. She covered health for Reuters on Capitol Hill for more than a decade and wrote about end of life during a Kaiser Family Foundation Fellowship in 2007. Joanne Keenan's work has appeared in The Atlantic, The Washington Post, Slate, Kaiser Health News, and Health Affairs, among others. Welcome, Joanne.
Thanks for having me back, even if we're not in Aspen.
All right. So we're honored to have both Dr. Harris and Joanne with us today for this important conversation. Thank you both for being here. And with that, I'll turn the mic over to Joanne. Have a great conversation, everyone.
So thank you for joining us, even if we're not in a mountain. If you were at Aspen, you've probably heard me say that the task of health reporters is we spend a lot of time chasing after bright, shiny objects. And as soon as we get our arms around it, they're gone and we're on to the next one. But I think the conversation about social determinants of health and about disparities and equity in healthcare is way more than a bright, shiny object. I think before this pandemic, we were just about hitting a tipping point in that it was becoming part of how we actually thought about healthcare in a broader way. We were thinking more, we weren't solving anything or everything. We were maybe solving a few little things, but there was really a greater understanding of the need to build bridges between the silos of social services and medical services to bring in a mental health as part of patient care, also in a less segmented way. And then this crisis hit, the pandemic hit. And we were talking before the broadcast, and I said that in some ways disparities it's the pre-existing condition of our healthcare system. And right now it's hitting us with full force. And what I want to talk to Dr. Harris about is a little bit about how bad it really is, because it's really bad. And I want her to talk about what she's seeing. But then I want to spend most of our time talking about moving ahead, because at some point the pandemic will be over, but those underlying disparities will still be there. And the issues of equity will still be there. And this is going to be a challenge to not just forget and move on. So let's just start, when you think about what's happening and when you think about how this epidemic is hitting, it's not that it's only hitting, poor people or minorities or ethnic groups. I mean, it's in the White House. What has really struck you and really, gut punched you about how certain communities are really bearing a disproportionate share of this really unbearable burden?
Well, Joanne, first, it's good to be with you again. I think we were talking before the broadcast that we had conversations around the opioids, and I really like the title of this session. It's the floodlight, because for many of us, and as you know, we've been talking about health disparities and health inequities, but I'm not sure we were really at a point of getting to action. And so I hope you are so right, although I do believe that we will have to take the power in our hands to make sure this is not a bright, shiny object. So I think this conversation, of course, and others will begin to hopefully make sure everyone has a commitment to this post the acute phase of the pandemic. I have to say, not surprising on this, because again, knew that these inequities were already in existence. But when I saw the first data come out of, I believe it was Milwaukee, that the first 10 patients, I believe that number is correct, but even if it was the first 5 were African American, of the first number of deaths, they were all African American. That actually was a gut punch to me. Again, not surprising, but certainly here we are. And when I've seen the numbers continue to come out from other cities, how about St. John the Baptist Parish, that at one point, when we were all, of course, appropriately focused on New York because, the numbers were there, but St. John the Baptist Parish had the largest per capita share of deaths. And so, and of course, all African-American, primarily African-American communities. So those things certainly were quite disturbing and distressing to me, but certainly now for all to see and know.
In the first few weeks of the pandemic, there was also a lot of trouble getting data out on how various communities and ethnic groups were being impacted. I believe it was in early April it started coming out. All of us are a little fuzzy about time these days, but I think it was early April. Is it enough? Did it tell you what you needed to know? And why is that data so important when it's in the headlines, we see it? What did you need the data for?
So it's certainly not enough, but let's begin with data and science and the evidence around this pandemic, and actually any public health crisis or health crisis. We all have to be committed to that. There's so much misinformation out there regarding COVID-19 and other issues. And so that is why the AMA has been focused on ensuring that everyone use data-driven decisions as we get through this and make our way through this, and also the science and the evidence. So the data was first coming out, but certainly we realized at the AMA almost immediately that it wasn't universal. The data wasn't being collected universally, and the data was not being collected in any standardized manner. And so that's why early on we sent a letter to HHS asking that they collect this data. And of course, not only collect the data, but then disseminate it. And then all of us have to partner in analyzing the data. So you can't fix a problem, if you will, unless you identify it and have a good set of data around the problem. So that's why it was and is and will be important that we continue to collect data around race and ethnicity. And by the way, we do need to get down to zip code data, right? County level data, because, we've also heard that in addition to the disproportionate deaths and hospitalization and worse outcomes, tests weren't available. Tests weren't equitably available in some of these very communities. So we need to get the data so that we can really target our interventions to those communities in need.
What are some of the social factors when we talk about social determinants? There are many. What are the things that you think contributed to this really disproportionate impact, in an urban setting like New York versus rural Louisiana? What are some of the things that you think are the contributing factors?
And Joanne, you and I've talked about this before. I think we talked about this around the opioid epidemic, and I just want to stick a pin in the fact that language is very important around this, has been, will be. We talk about inequities, we talk about disparities. So I'd just like to say at this moment, and there are so many other issues around language, but disparities are sort of differences in health outcome. But inequities, and the way we look at it at the AMA, are those differences that are unjust, systemic, unnecessary, and actionable. So we really want to make sure we are grounded. And in the future, and I don't always use the language that I should use, but I think we should commit to using language. And then we have the social determinants of health, which are lack of access to housing, living in food deserts, transportation. But we also have the structural determinants of health that we have to talk about. And I will admit it's often more difficult when we start to talk about a bias, both implicit and explicit discrimination, and even, structural racism. We have to have conversations about all of that if we really want to understand and appreciate and get to action around these drivers, factors that lead us to where we are regarding inequities.
One of the issues is as we go away, at some point, the worst of this will be over, and who knows when. People will have been hurt. I mean, the whole world's been hurt, but again, that won't be evenly distributed. There'll be some people who are hurting more. Many of the people who are most at risk have other chronic diseases, and we know that some of the bills in ways that are still not clear are going to be, when you're in the hospital, you're going to get the hospital's going to be paid by the government. We know there's some stimulus money going. We don't know if it's covering everything. We don't know. There's a lot we don't know yet. But some of these needs are going to be, we don't entirely know the long-term impact of a severe case of COVID on the body. I mean, I know people who are still having trouble walking more than a few blocks. We're young and healthy, and it's a bad disease that we don't totally understand. People already had these chronic conditions: diabetes, asthma, high blood pressure, a whole host of chronic diseases. What do you worry about in terms of an equitable approach to not only addressing the pre-existing conditions, but whatever new ones are going to be piled on, plus unemployment, uninsurance? I mean, we're going to have a lot of social problems in many communities, many families.
Absolutely. And so here we have a crisis, COVID-19, on top of an already existing crisis, right? The increased number of African Americans and those from other communities of color who were already impacted by higher rates of diabetes and hypertension. And those are the very diseases that made someone more susceptible to the worst outcomes, not susceptible to the infection. This is an equal opportunity virus, and all of us are equally susceptible to becoming infected. But of course, it is then having the worst courses and the worst outcomes. And again, on top of already issues around diabetes and hypertension, any pre-existing lung diseases. And of course, let's not forget, in addition to social and structural issues around insurance, right? And I live in the South, I live in Atlanta. Not every state expanded Medicaid. We know, I think you and I chatted about this regarding substance use disorder treatment. Medicaid was very instrumental in ensuring that more people had access to substance use disorder treatment. And the same goes true for health care. And so, again, living in the South, and a large number of African Americans who are uninsured, of course, not just the South, but a greater proportion in the South. And, I live in a state that did not expand Medicaid. So I worry about access to care. As we get on the other side of this, and we need to continue to elevate that. We want to make sure. I worry that we are going to have to, although I am going to say, and I know the AMA is committed to this, we're going to channel our worry into action. But certainly worry around transportation and, access to food and all of these issues that we know already exist. We are going to have to make sure that we address some of the issues post-COVID and the new issues that you mentioned that we may not know about. We may not, for months or years, be able to fully appreciate the impact of this. And so we are going to have to stay committed to getting the data, back to our first point, and getting the data by race and ethnicity and zip code so that we can target interventions. And so there's equitable. We at the AMA define our work as making sure everyone has an equitable opportunity to the best care and wellness and living their most productive, fulfilling life. That doesn't mean everybody needs the same or gets the same, but people get what they need so they can have those equitable opportunities.
Looking at the conditions that may have contributed to how intensely some communities have been affected, and at this sort of long list of so when we're talking about linking social and medical needs, what do where does the first round of energy? I mean, the first is going to have to be jobs, but after jobs, is it housing? Is that what you think is the crowded housing? Is that why it spread? I mean, we know there's a lot of links between housing and health. Is that, I mean, or is it impossible to prioritize and say there were 100 things went wrong and we have to address all 100 of them?
Well, certainly realistically speaking, we can't do 100 things at once, but I probably wouldn't prioritize one over, I don't know, 6. And so we'll, need to have conversations about access to healthcare. I guess in the acute, you're talking about post-acute, we'll have to actually definitely have the data and then make sure that, and we could prioritize, for instance, if we know a particular zip code has been hit hard, we may need to prioritize that zip code or that community. And we need to, here's another point of fact as we get on the other side of this, we have to make sure we have the input of the community as to what they need, as opposed to sort of swooping in and deciding, someone else externally deciding, but it is a partnership in deciding how to best impact that particular community. And it will be different because there will be different health assets, in a particular community. And so we will have to make sure that we are getting that community input. But it's housing, it's access to health care. Again, it's making sure we have the data and there's a focus. We talked about it living in denser cities. Not everyone had the privilege of working from home, so we had essential workers go out.
Which there's
exactly.
There's a class and economic line there.
Absolutely. So I can't prioritize that. There will be 3 or 4. We have to look at actually the research. Actually, that will be a piece of this as we actually get to vaccines and treatment. It's a little bit before we get to the other side to make sure that people from communities of color participate as we develop solutions on the science side and the social side. Yes.
That's one of the questions I wanted to ask. There's been difficulty in doing clinical trials that are really representative of the population, even gender, even though it's been the law since the 90s. I mean, we still have a lot of scientific studies are not representative of what our country and our society looks like. There are issues of trust but it's also really important as we're going to be working really hard, as we should be, really warp speed to get therapeutics out, to get vaccines out if we can. What are your concerns about, and are you seeing any efforts made to bring in a representative population, and are there trust barriers to doing that? Because if it isn't, there's going to be trust barriers on the other side when we do have them. Who's getting them and why are they getting them and how do we allocate and who trusts and who takes, and there are a host of issues.
Well, there are absolutely trust barriers. And I'll just say, I know you know this, but sometimes we assume that everybody knows and appreciates the story of the Tuskegee experiments. And, often you probably hear this, I hear this, well, that was X number of years ago, whatever the issue is. Aren't we over that now? No, there's still the lasting legacy of that in the African American community. And so we do have to, I'm an African American, but still I work really hard to make sure that I'm credible. And I am a credible source of trusted information. I'm transparent. I tell people, I do this actually with my patients, and I feel like I do this on the community and organization level. I think, trust and confidence, quite frankly, are very important as we get through this phase of COVID-19. We have to tell people what we know. We have to tell people what we don't know. We have to, again, be transparent. And so, trust is earned. And so those of us who want to be trusted have to work hard to earn that trust. And so we have to first start with, the incidents that led to that, and then work with the community. And we have to appreciate who are the influencers in a particular community, bring them in, and just work hard to build trust. And I think part of that will be critical before we can, and we still do encourage and have encouraged. I know I have individually, and the AMA encouraged, to outreach to communities of color when it comes to research. But it's about asking the question, and I'll just vignette, a little bit related, hopefully I can. When I was in training and we had a 70% no-show rate some days in our clinic, and folks would say, oh, we have a 70% no-show rate, and it was almost, that would be the end of the conversation. So the conversation has to be beyond the data and the science. We have to appreciate the narrative. Why do we have a 70% no-show rate? Transportation, childcare, all of those barriers. And so we have to ask the question. We have to get beyond, okay, here's what we have, and then ask why, and then go beyond the why to try to solve the problem.
So I'm working in some of the questions we have, and here's a good one. What are you hearing from doctors in the field as they confront and see these inequities? And what do they want other people to know?
Well, I think the physicians want everyone to know to trust the science and the data. That's the first piece, because when we are out there and we're saying we're not making up the data, no one is trying to inflate the numbers in general or for African Americans. So I'm hearing that worry and concern, and I'm hearing other issues about support to address some of these other issues, these other determinants of health. And let me just say, I know you know this, this is not physicians' a problem alone to solve. We have to do this as a partnership. I would say this is an all-of-nation approach. Physicians are absolutely in a great place to see the results and to see the health inequities, but then we need to make sure there are support, system support, policy support, and broad partnership support to address some of these issues. So it's not the physician's problem alone to solve.
If and when there's a vaccine, there's not going to be enough for everybody right away around in the US or globally. And there are going to be hard decisions on how to allocate them. What are your worries in the context of this conversation about making sure neighborhoods, communities, ethnic groups, racial groups, rich, poor? We didn't see a great distribution of remdesivir last week, although that was just sort of incompetent, maybe, rather than it didn't go to red states instead of blue. It didn't go to cities. It just sort of went places illogically, and they fixed it, or at least we think they fixed it. But it wasn't a real reassuring sign. A vaccine will be even more intense, right? A vaccine. Yes. We're just not going to have a lot of it just because the nature of producing a vaccine. We won't have a lot of it right away. What is that? What are you afraid of? And then what are the steps to make you unafraid? What has to be done?
Well, and so I use the term equitable a lot, because we will have to have conversations now. And so that's a great question, an important conversation about the distribution even before. And actually, I have, so I'm worried about that. I'm worried that the distribution won't be equitable. I have seen actually some signs where people are, although they're not really having this conversation in terms of equity, but they are having this conversation in terms of the amount, the need. And so typically, this is a linear process. We develop the vaccine and we do that, and all that has to occur, and those trials have to occur, and we have to make sure it's safe and effective. But I am heartened by conversations that while the research is going on and they're talking about development, they are also talking about distribution. So at least that's the conversation. In fact, I early on had a conversation with Dr. Aletha Maybank, who, by the way, is our new Chief Health Equity Officer at the AMA and will be leading our Center for Health Equity. We talked about the fact that often conversations around, oh my goodness, when we look back on the COVID-19 pandemic, we saw in the past tense that it impacted communities of color. The good news about that is we're having the conversations now, because usually these issues are an afterthought. And so I have to say I am heartened. We're having this conversation now, and others that we're having, that pre-thought, if you will, even in the midst of this. And so we need to have those conversations, and we have to use data, I would say. If a particular group has been disproportionately hit, I mean, I am no expert in vaccine prioritization, but I would say that it makes sense, just like we look at the highest need and at least make sure that there's equity in the conversations about how we distribute vaccine.
There's a lot of conversation about giving it to first responders first, but even then, who's going to define, how are we going to define first responders? Who is a first responder? And there's room for a lack of equity, even as those definitions are drawn up.
Absolutely.
This isn't over. I mean, people talk about wave 1 and wave 2. I think, one may just wave itself right into the next, but it's not going away in the next couple of months. Maybe it'll get better. Maybe we'll reopen smartly and not trigger a lot more cases, but it'll still be here, and the healthcare system still be coping with it. What advice do you have for doctors and hospitals around the country? I mean, there are issues too in rural areas, for whites and for blacks. There's different infrastructure there. There's different stresses. What sort of 2 or 3 things that you can say that you want them to be aware of? And then one more keep this answer quick, and then I'm going to close the question part with a brighter one.
Okay.
Most of this is pretty depressing.
Well, I think sort of an asset review is critical, and each local group should look at their assets in their community. One of the reasons we wanted to make sure at the AMA that practices were viable, because often, practices, particularly you mentioned in rural areas or other areas that were under-resourced and had access issues, need to survive. And so, I just want equity to be at the top of the top 5. Let me say this list of things that we do as individuals and institutions. And by the way, let me just get this in there. You talked about what may happen, and we don't know. But here's one thing I want everybody to know: we have the power in some ways, or certain things we can't control, but there are things we can. We have the power to determine some of the infections rates by wearing face coverings and staying away from folks and no large gatherings. So I am, when I wear a mask, I feel like I'm helping, and I'm doing one great thing to ensure that I can get into the Atlanta Falcons football stadium in the fall. That's how I look at some of these things that I have to do right now.
My mask is full of little girl scientists.
Yes.
So when I wear it, I'm empowering somebody who sees it.
I love that. I want one of those. If you can get me one of those, I'd love to have that.
And the last question, we're running out of time. I want to stay on time, but someone asked a really important question, maybe the most important question I'm going to ask you. What gives you hope?
What gives me hope are people. Most people want to make sure that we get through this and that we get through this together. And so that always gives me hope that there are enough people who have in the past shown that they're interested in doing the right thing, and the best predictor of future behavior is past behavior. So I'm holding on to that hope.
Okay, well, I do want to wrap up on time, because we've all learned over the past 2 months there's only so much Zoom one can tolerate.
Yes.
This is a really important conversation. I'm glad we had it. I think that, one of the takeaway, I think, is what Dr. Harris actually began with, which is these problems don't go away when the virus goes away. And the challenge is going to be to take those conversations, that awareness that was beginning to seep in, that this is a healthcare and the social aspects are intrinsically related, and that we don't lose sight of that, and that we understand that these communities that are struck disproportionately because of the inequities, that we dig in for the long haul so that they come out stronger, and we have a system, a healthcare system, and a social system that does not have the word inequity written all over it. So Aspen is we cannot get, Aspen, it's like my favorite time of year. It's both this incredibly stimulating and incredibly relaxing at the same time. And we're not going to get to go there this year, but it is an honor, as always, to be part of the conversations. There's a whole series of wonderful things planned. So you should keep track and join the next one. And thank you for joining us today for what was a really a conversation that we need to have frequently and remember. Have a good day, everybody.